today is going to be focused upon, I wanted to talk a little bit about, we keep talking about ectopic fat. I thought we'll also talk a little bit about what I'm calling eutopic fat.
Absolutely. So one rule is that please interrupt us.
Yeah, please do.
You can call me names also.
No issues. Discussion. And I learned a lot, and as always, I'd like to share. So these are some of the questions that I wanted to answer when I started reading about this. So is ectopic fat in a location where it normally is not found, or is it excess fat in a location where there is normally fat to be found? Why does it behave differently when you have excess amounts of it? Why does it behave differently because it's in a different place, and how exactly that leads to diabetes and of course all of the other non-communicable diseases? So a little bit of a primer on fat. Just a quick word about what I'm calling eutopic fat. Anyway, this is where fat is normally stored in our body. So we all know about subcutaneous fat. We know about what we call as visceral fat, which is the fat in the mesentery. It's also the fat in the omentum. And we'll talk a little bit about the differences between these types of fat. But fat is also normally found in the blood vessels, around the heart, around the kidney. And then, of course, we have this brown fat, which newborn babies have a lot of, and there is a lot of work looking at it. Interestingly, I also found that we have still deposits of brown fat along the, what I consider the sympathetic chain, along the sympathetic ganglia. So that I thought was interesting, Krishna. So I'd like you to talk about, is all of this fat the same?
I hope not, because where the fat is present tells you whether you're ugly or not, right? Look at me and look at her. So where the fat is deposited tells you where it is. But interestingly, fat has a history, right? Remember that, and especially for humans, this is very important. Why? We are the only two species that has the greatest amount of survival advantage. And the story of human survival is the story of fat. We did two things to become who we are. One, we gave up the reproduction efficiency that animals have. And instead, we bought for ourselves adolescence, so our kids don't leave us till they're 70. The second thing is we have the largest size brains in the world. And why do we have the largest size brains in the world? The brain is like a fetus. So thank you. The brain is like a fetus. It is an obligatory glucose consumer, except, it consumes ketones. So the reason we have fat is, and the reason we have insulin resistance is, that when glucose is not available and there is a problem, you need fat to be supplied to all the muscles and the others. And insulin resistance is also present because it shuts off the glucose supply everywhere else and forces it to use fat. So that's really what fat is doing. It's a reserve fuel. It is there, and it is present. But the thing is, fat is toxic. It is stored, it is very efficient, and it is stored in the visceral compartment, in the subcutaneous compartment. In women, it is gynoid. In men, it's android. But also, the amount of burn it does. And that's why you have these three. The white, the brown, and the and it's okay, and the beige. Now, brown adipose tissue we thought was something that only babies had, and those that were hibernating. But the reason brown adipose tissue, it's not energy efficient, but it burns a lot, right? And for a long time, we did not think that adults had brown adipose tissue till the era of nuclear medicine, when they started looking at brown adipose tissue in the neck, in everywhere else. And if you have good amount of brown adipose tissue, you lose weight. And how do you get brown adipose tissue? Go stick your head into the refrigerator every day for 30 minutes now. Or go take a polar bath. Or eat the food that Dr. Vijayakumar serves, avocado. Spicy Indian food has the beiging episode. So one of the things we now talk about it, so there is a protein called the UCP2, the uncoupling protein 2, which is expressed in brown adipose tissue. In white adipose tissue, it's not present, therefore it's just a storage mechanism. But by diet, by exercise, by eating the right kind of food, you can convert white adipose tissue, you can brown it, and that's why it's called beige adipose tissue. And that's the big area of research in this. So that's the kinds of fat, besides the one that I have in my brain.
Yeah, so what we are conventionally used to thinking about as a subcutaneous adipose tissue is relatively more of the white fat. It's about 80% of the fat in our body. It contains a lot of smaller insulin-sensitive fat cells, whereas the visceral adipose tissue, which is the one in the mesentery, in the omentum, have larger adipocytes which are more resistant to the action of insulin and therefore more sensitive to lipolysis. They have more ability or the more propensity to release pro-inflammatory cytokines. Why do we even need visceral fat? It is believed that visceral fat evolved as a way to protect animals from intraperitoneal pathogens. So they needed, when you fast, actually our visceral stores are lost very fast. The previous topic was all about remission of diabetes, and ultimately it does come down to caloric restriction. We all have to eat less. So when we eat less and there is caloric restriction, one of the things that goes down very fast is the visceral fat stores. So ectopic fat, to my mind, Krishna, and tell me if this is correct, it is excess fat in areas where it is normally found. So for example, when we have increased visceral fat, when we have increased epicardial fat, but it is also accumulation of fat in areas where it is found in very small quantities and it increases. So this is the liver, the pancreas, and the muscle. Is that fair to say? How would you define it?
Absolutely. And the thing is, if you find these fat, there are two parts to it. One is the physical presence of the fat itself. But I think when it's present in areas that it is not present, I think you should also assume that there is coexisting inflammation. It is not just a benign appearing fat that is present, but when it is present in an area that it should not be, it tells you there is systemic inflammation. So I think that is the kind of thing that you should start.
It is a non-adipose tissue area.
So yes, but the thing is there are very few non-adipose tissue areas in the body, right? But the way you would look at it is where it is not normally present in other than, a minute number. So even in the pancreas, there is some amount of peripancreatic fat that is normally present, but it is excess amount of fat, interlobular fat, dissecting the facial planes, then you call it ectopic pancreatic fat.
You got also in the osteocytes in the brain.
Sorry?
Osteocytes in the brain also you got fat accumulation.
Yes, I'll be talking about that. We'll be coming about fat in various areas. I think the previous topic spoke about it. This is your favorite thing, Krishna. Can you lead us through this? Why do we get accumulation of fat? Why does it not accumulate in areas where it's not going to be harmful, like in the subcutaneous area? So what happens because of this?
So I think, I've been talking about this for years, and what we need to remember is that every time you have caloric excess, you're actually creating inflammation. So today's lunch, you will have neutrophilic infiltration into your stomach. Now, what happens is the fat cell is programmed to expand. That is how it is, a signet-shaped ring. But at some point of time, inside the fat cell, when you keep accumulating it over a period of time, the first step is the activation of the mTOR pathway. When the mTOR pathway is activated, the fat cells develop insulin resistance. When the fat cells develop insulin resistance, there is a signal that is sent to the bone marrow, and you have macrophages that are CD4 positive coming into the abdomen. That's where it starts. This whole thing starts in the abdomen. Actually, they're coming in as helper cells. They're coming in as helper cells. But once they go into the abdomen, they undergo a phenotypic shift, and they become actually killer cells. Now, the presence of the fat cells, the fat cell that is already insulin resistant is making adipokines. Leptin, adiponectin is going down. There are chemokines that are being produced, IL-6 and the rest. So actually, unlike our jugalbandi, there's a toxic jugalbandi that is going on there. The adipokines feed on it, the chemokines feed on it. At some point of time, the fat cell undergoes apoptosis. The fat cell in the visceral tissue compartment undergoes apoptosis, and fat becomes ectopic. Until fat becomes ectopic, there is no insulin resistance. It's very interesting. The entry of diacylglycerol into the liver is a prerequisite for insulin resistance. Till you have fat in the liver, there is no systemic insulin resistance. So what is happening is, this is Roy Taylor's thing that has been redrawn. So there is caloric excess, there is insulin resistance with liver fat, increased basal insulin secretion, resistance of insulin suppression, glucose goes up, there's islet cell triglyceride, and we'll talk about pancreatic fat, but in each places, and to just add to it, some of this is mediated by my favorite molecule, FOXO. FOXO is involved in this insulin resistance that's occurring in there. So one of the simplest way to, this is the twin cycle hypothesis. As long as there is fat here, there is diabetes. You take the fat back, there's no diabetes. That's what the direct study showed. Please free to ask us questions. Yeah.
Yeah. But why exactly, Krishna, is it that fat, I mean, you touched a little bit about it, but why is really fat toxic within the cell? I think this comes back to another favorite molecule of yours, which is DAG, I think you'd put it.
Right.
Yeah.
So see what is happening. It's very interesting, you know, and I will talk a little about mitochondria in the afternoon. So remember, what is happening is that there is a fuel partition that is there. That there is glucose that's available when you're eating, and there is fat that's available when you're not eating, right? But what now happens is there is a mixture of fuel. Glucose is available all the time. Fat is also available all the time. And therefore, what happens is, at the level of the respiratory chain, there is an overload into the NAD and the FAD pathways. Therefore, there is a rate-limiting step in the mitochondria, which is the cytochrome oxidase, which is level 4. And when that happens, there is a proton leak that occurs into the mitochondria. When the proton leak occurs in the mitochondria dysfunction. In the liver, it's insulin resistance. In the pancreas, it is beta cell dysfunction. So at the bottom of all of this is that there is mitochondrial dysfunction that is occurring here, and therefore you have increased gluconeogenesis, increased glucose, and also see what is happening here. Now, each time, remember I said insulin resistance is intricately tied to inflammation. Why? You pointed it out. Because every time you have no glucose, it means it is flight or fight mechanism. So body is not able to get food, it releases fatty acids. When does it not get food? When it is running away from infection. That is why the inflammatory and lipolysis pathways are very intricately linked. And some of these are controlled by the microbiota. This is the big player that we don't talk about, that microbiota are probably, and remember there is a gut microbiota brain axis. So our eating behavior, all of these are also controlled by the microbiota. So it's an intricate thing, but it is lipolysis, inflammation, mitochondrial dysfunction, insulin resistance, beta cell dysfunction. Same thing happens in the heart. Just to add that in the heart, the only difference is the heart generally uses fat as its main this thing. A lot of us think that it's glucose. It's not. The heart cannot depend on glucose because it needs fuel all the time. The heart uses fat. If it shifts to glucose, then there is something wrong. Epicardial fat, sir. It has UCP1. It does not have UCP2.
So coming to a little bit about the fat in the muscle, I just wanted to clarify some terms. So there is something called IMAT, which is the intramuscular fat, which is the adipose tissue between the muscle fibers, adipocytes. And then there are adipocyte collections between muscle groups, and that's called intermuscular fat. And then there is IMCL, which is intramyocellular lipids, which is the lipid stored within the myocyte. So all of this together is what we call as the muscle fat. Of course, we all know that muscle fat is bad. It increases insulin resistance. But apart from the fact that it increases metabolic dysfunction, insulin resistance, what I found interesting was that this increased muscle adipose tissue is also associated with a muscle dysfunction. There's a reduction in muscle strength, there's a reduction in muscle quality activation, which also then leads to mobility dysfunction. So all the changes that we sort of see as we get older, we are walking less fast, our physical ability, physical performance comes down. This was a nice paper that I came across. So this is a person, you can see that both of them have the same lean body mass, but this person has much more intermuscular fat. So this person has all the parameters of the muscle strength test. So how fast are they able to get up and go, how fast, what is their lower extremity power, all of this is significantly less in the group. So they have the same amount of muscle but more fat. So with increasing age, muscle strength is reduced more than can be predicted by the loss of muscle mass alone. This is because of the excess adipose tissue. And like Krishna said, fat is not just the physical fat that is present. It induces this inflammation, this whole sort of inflammatory cascade, cytokine release that occurs also affects muscle function. But this is another factor we need to keep in mind. I think Dr. Lakshmanan was talking about making sure that we improve when caloric restriction is there. Muscle mass shouldn't be lost, yes, but we do have to lose the fat while preserving the muscle. And similar to how Krishna explained about what is the insulin resistance level, ultimately it all comes down to this. When there is an increased fatty acid flux, because you have excess fatty breakdown, there is increased influx of the long chain fatty acids into the cell, which inhibits the function of the insulin receptor. So the ability of insulin to activate the insulin receptor is blocked by the presence of these long chain acyl CoAs, which then accumulates within the cell, which of course means that the muscle which acts as a sink for the glucose is not able to act as a sink for the glucose. Remember that most of the action of insulin is to make sure that the muscles open up and suck in the glucose after we eat. That doesn't occur, which is why you have significant, particularly postprandial hyperglycemia in the presence of excessive adiposity in the body. Of course, this is one simpler explanation, but this is simplistic. I wanted to spend a couple of minutes talking about fat in the brain, because one of the things I came across was that they did a wonderful study where they compared the type of fats that we have in our brain across different species. And it showed that as human cognition evolved, the types and the amounts of fat that we have in the human brain was very much more different compared to even our closest sort of the chimpanzees, the other closest primate ancestors. So they feel that this ability of our brain to use or to develop or to have different types of fats was one of the things that helped make us human, like Krishna said. The other important fact is that the brain is 60% fat. It is the organ in our body which has the highest amount of fat after adipose tissue. So when we lose fat, we need to make sure we are not also losing brain.
There's nothing left here.
Yeah, you need good fat. So what do fats do on the brain? Of course, this is a very complex picture, but it is, of course, a neurotransmitter. It is the myelin covering. It is also protective of the nerves. It leads to myelin stability. It's important for neurogenesis. So you need good amount of good fats in the brain to recover from, say, some sort of an insult.
So it's funny, Jaishree, that all your life you've been said, "Romba kolpam moolele irukku."
Yes.
You actually needed that
kolpu. That's a good thing,
isn't it?
It's a good thing. What do they say? Head weight. Head weight. Yes.
Amridamam Visham. Correct.
So you need the right amount in the right place at the right time. So I call it the Goldilocks theory of fat.
So very interesting. Can I just add one more thing, Jaishree?
Yes,
and
please.
Some years ago, there was this very interesting argument about Alzheimer's dementia being type 3 diabetes. Because there was a beautiful work that showed what is happening in the brain in diabetes due to insulin resistance has all the hallmarks of inflammation. Absolutely. Got it. See? Talk about it.
So there is this fatty acid sensing neurons in the hypothalamus. So they will signal either nutritional sufficiency or insufficiency and then direct the liver. So there are actually direct signals, what you were talking about, the gut brain. This is one of the ways the gut tells the brain whether we have enough or not. Unfortunately, and I think you'll agree, Krishna, we don't pay attention to it.
Interesting, because we are so pancreas-centric. I don't know how many of you remember that the original descriptions of diabetes were by Claude Bernard, where he actually pierced the floor of the fourth ventricle, picare of the fourth ventricle, and he demonstrated glucosuria. And a lot of work shows how the brain actually controls diabetes. Of course, it should.
Seems a bit of an extreme measure to cure diabetes, but...
So it's probably leptin mediated. So one of the things that's happening is that one of the strongest. So there are two sets of neurons in the brain, the orexogenic and the anorexogenic. This is in the lateral hypothalamus, and there are inputs that come into it: hedonic inputs, food, eyes, behavior, inflammation, gut microbiota, and importantly, leptin and adiponectin. We probably think that leptin is the key. For example, the previous discussion on caloric restriction. One of the first things that changed with caloric restriction is a reduction in leptin. And why is it that there is no caloric restriction? Caloric restriction does not cause insulin resistance, is that leptin probably brings down the insulin resistance. So pretty much, our knowledge about this is so superficial, very, very little, but we are learning more and more from functional MRIs. But leptin seems to be the key.
So again, an interesting observation that the higher a visceral adipose tissue, the lesser a gray matter density. And I think it also makes it, I think this partly explains why it's so difficult for us to be able to control our appetite. There are other changes that are occurring in our, in the brain, over and beyond just the willpower.
One more thing that, this is something that we need to start remembering is when we take care of patients, a lot of times when we talk to older patients, we think they're belligerent or they don't listen to us or they've forgotten. But actually what is happening is there is a loss of executive function that goes with the cognitive dysfunction that is associated with this.
Yes.
A lot of times we blame patients. The answer is no, we haven't found out what the problem is.
So yeah, your favorite topic, Krishna, pancreatic fat. This is just an ultrasound showing about how there is diffuse steatosis in the pancreas, and this is what a normal pancreas should look at. So apart from a fatty liver, we should also be looking at the fatty pancreas. Again, similar, this is a picture which shows a person with diabetes and hypertension, and you can see how compared to a person who has, so blue is very little fat. You can look at the pancreas. It has green, it has a lot of abnormal looking blues, lesser blue. This is because of fat accumulation in the pancreas. But I'll let you talk about the inflammation in the beta cells here.
So this is something that I have been chasing for a while, simply because of my admiration for one man, Mark Doneth. He was the first person who demonstrated inflammation in the beta cell. And from the time that has happened, diabetes has been an inflammatory disease largely because of that kind of work. What is happening is the same as what occurs everywhere else. That there is the pancreatic the beta cell, there's a macrophage, there is an interaction that is occurring, probably mediated to a large by IL-1, because there was a time when a drug called anakinra was actually thought to bring in remission in diabetes. But what is happening is the activation of the inflammasome, the NP7 pathway, and then the NF-kappa B being activated. The one twist to this tale is, till about 2012-13, we thought that these cells died. But now we know that they don't. Beautiful work by Chianti et al. That showed that there is a reversal, that they lose. Why do they reverse? So after the heart, which has the greatest amount of ATP in mitochondria, it's a pancreatic beta cell. The amount of energy that is required to make insulin, if in this toxic environment, if the mitochondria do not regress, the cell will die. So what really happens is it shuts down the insulin-making apparatus. It starts making either glucagon, more likely ghrelin, or just a non-hormonal endocrine cell, and just regresses to that. So the beta cell mass doesn't change, its functionality changes. It is like that lady who's waiting for you to, you have a drunkard husband who's coming home late every day, but this lady is still waiting for that one day that he comes home sober. And these cells are waiting for you to lose your fat, lose your thing, and start producing insulin again. I think that's the story.
I was just saying, I thought we can call it the Kumbhakarnan hypothesis.
Yes, they are sleeping.
So to answer someone's question about ectopic fat in the heart, very quickly, this is where the fat in the heart is normally stored. It is between the visceral and the parietal pericardium, the epicardial fat. Epicardial fat produces a number of cytokines which have both pro-inflammatory, protective action, and pathological adipokines. In the interest of time, I'm skipping. But one other thing I wanted to say is when there is excessive fat accumulation, it also increases the risk of atrial fibrillation. So the fat actually infiltrates the myofibrils and prevents that proper transmission of the signal. And how commonly do we see this? Diastolic dysfunction, grade 1 diastolic dysfunction. Remember that this is a good marker for myocardial steatosis. So you don't need big biopsies, you don't need big PET CTs. L1DD, one of the factors is myocardial steatosis. So this is again an important thing to keep in mind.
So one request I have is next time you order an echocardiogram, please ask them to include a particular parameter called EE prime, right? EE prime that is more than 15 is indicative of HFF and myocardial dysfunction. So it's a simple thing that all of us should be asking our echocardiographers to put it in. What is the EE prime?
So another
It should be done
another sort
routinely.
of point that I came across.
Well, you really, actually the truth is that in clinical practice you don't need to quantify the fat in myocardium, because when you have insulin resistance, your triglycerides are elevated, your waist is high, you're bound to have fat in the myocardium. But diastolic dysfunction is a completely different story. It's an indicator of it, but not necessarily always a cause of it. Nowadays, one of the simplest ways is if somebody has diabetes for more than 10 years, get an NT-proBNP. If it's more than 125, then do further studies.
So which fat do we need to be most concerned about? Pancreatic, muscle, liver? A lot of us are talking about NAFLD, but I came across this very interesting study which showed that the pancreatic fat, so this is people without diabetes and this is people with diabetes, and you can see that the increase in pancreatic fat is the strongest predictor of developing high fasting plasma glucose and blood diabetes, followed by muscle fat, followed the last by liver fat. So I don't know if that...
well, when this article came out, a lot of discussion was going on. So it makes sense, right? It's already reached a point where the fat around, pancreatic fat is one of the last to get deposited. Earliest is liver and muscle fat. So you've already gone beyond that stage. But the way I would look at it, it really doesn't matter. A fat that is ectopic is abnormal and needs to be addressed. Exactly, absolutely.
Yeah. So to answer the question that someone asked, what are the markers of ectopic fat? And I thought we'll just talk about simple, advanced, and complex methodologies, Krishna. What you exactly said. Simple markers are these. Anything else to add? High triglycerides, low HDL, blood sugars, uric acid, CRP, calculating FIB4, NAFLD scores, ESR, platelet, WBC. All these are markers of inflammation, I think. An ultrasound, simple ultrasound abdomen. Anything to add to this?
So I would just single out two things. One is I think that triglyceride, waist, and the FIB4. This is an underused score in our practices. I think all of our patients should have a FIB4 score done. If you have an EHR, REHR is calculated, but at least carry an app. It is a very, very important step. Because an AST and an ALT or an AST-ALT ratio does not predict NAFLD. A FIB4 score tells you about progression from S1, F1 to this thing. So if the FIB4 score is more than 1.6, I get a TWE, trans-wave elastography. Otherwise, most of these don't require any great testing. A triglyceride is something that you're going to do every year. A waist is something that every patient should have. A FIB4 is a simple calculation from what you have. So nothing earth-shattering, but it's worth doing.
Just a word about the FIB4, Krishna. When we were looking at our data, we realized that a lot of the patients with diabetes had a FIB4 score which was below 1, in fact. It was higher than the non-diabetic population. I found some studies suggesting that a FIB4 cutoff should be lower in people with diabetes. So I think that's something we need to look at.
1.4 or 1.3?
I think even lower.
Even lower than that. So
on an average, we found a FIB4 of 0.9 in our diabetic and 0.6 in our diabetic, and non-diabetic was 0.6.
So one of the other scores that I would think about is the NAFLD risk
exactly,
score,
that's why I put it up.
Which is probably even more better.
Yes.
In a diabetic, I use a cutoff of minus 1.66.
Yes.
And anything more than minus 1.66 is intermediate in risk. When in doubt, get a TWE. My view has been that anything less than 1.6, you may see steatosis, but you don't see fibrosis. So when it's 1.6 or more, you probably get an F2 fibrosis, which is an actionable point of item. A steatosis is just weight loss and diet. I don't treat it. I just tell them it's part of your diabetic treatment. You really don't need any additional medications. So go ahead. Sir, yes, sir.
Clinical medicine, the strain, how does it correlate to the, of course, you said about US data. Clinically, the one thing, of course, we come over acatosis, but the stretch marks, which nobody likes, does it correlate with your...
It only tells you that there's a flux of weight. See whether you gained weight or lost weight. That's really all it is. The most useful is a waist just take an inch tape to the waist. If it's more than 88 in men or more than 80 in women, that already tells you it is there. And you really don't need much more. You can measure the neck, but I think the single most important thing that you can do in your practice from today is measure the waist. The same principle applies because the risk is much lower. The one thing that people are now talking about is to measure, go back to measuring triceps. Most people are now saying, you know what, we miss measuring the triceps, we should do it. Back. So, okay, so that's a long story, but I want you to know TSH mild TSH elevations, in my view, and we have published one study and there's another study that's been published, the greater the number of diabetic comorbidities, the greater is the risk of your TSH being mildly elevated. It's just a marker. I don't think you need to measure.
Finally, neuroendocrine modulation. See, we talk about lifestyle, calorie restriction, but India is a country with ours is yoga or asana. What we talked about the innervation, gut, all this innervation. Is it really useful? Your leptin level comes down, or so that we can the original research. We do all this research for the intestine. So if at all there is one thing which we do is that.
So, just to answer this question, I actually do animal work, and one of our funded work is on circadian rhythms and pancreatic what happens to it. We actually put rats through this is presented in the ADA. We put rats through a nurse's shift, and our original idea was to look at FOXO, but we looked at other things like PER1 and others. And what we showed was that with just one additional 8 hours of exposure of sunlight every second day, the increase in the pancreatic beta cell mass was higher. There was destruction of the pancreas. There was enzymatic degradation of the pancreas. So clearly, we do have Indian data. My own work is really a lot in the Indian knowledge systems. One of the work that we did sorry Jaishree, I'll take 1 minute, because a lot of people are not aware of Indian work. So one of the works that I have done, was published in DRCT about 4 or 5 years ago, was we looked at whether the simple oral microbiota, we were the first to publish gut microbiota in India in diabetes. Shashank has actually presented in many areas. One of the interesting things that we did was oral microbiota. That in diabetes, oral microbiota changes. But those of you remember that in India, there are 6 kinds of twigs that are used to brush your teeth. The problem with some of this is that you have to preserve the enamel. So what we did was we measured the oral microbiota, showed how inflammatory it is, and then we gave these people neem sticks with enamel protection for 3 months. And it showed a reduction in the MCP1 at the end of 3 months, a change in the oral microbiota, and a reduction in the A1C. So are Indian knowledge systems useful? Useful. Can we do research on them? Absolutely yes. Is it being done? There are many people who have done it. For instance, there's a group that has actually showed genomic sequencing of people or the various kind of doshas, the vata, pitta, kapha. And they showed that there seems to be genomic variation in the various buildings.
Ideally, the target should be medical students. From the DEET itself, we start burning the candle in both sides. We talk about diabetes here, but all of us are prone for all these metabolic consequences. Professor of Medicine, it is your job to go to the hostel, diet, exercise, and instill, in addition to teaching clinical medicine, it is a lifestyle. At least that you general physicians can do it for us. Thank you.
Jaishree, you want to talk about the direct study quickly?
No, I don't want to. I think the previous thing touched upon it, but I just wanted to say, I think ultimately it comes down to we need to be focusing on prevention. When we see a HbA1c of 6%, start taking it seriously, eat less, and you have to start early. Prevention, I think, is key. Just final words, Krishna.
See, I told you that she was Chitty Babu rolled in one.
Eat wisely. When they talk about anemia, eat wisely. Eat nutritious food.
Very good.
Thanks, Jaishree. Wonderfully
Thank you very much, sir, for a wonderful presentation. I can tell them they are the clinical scientists. They are clinicians talking like a scientist. So really, I congratulate both the presenters for the wonderful presentation, which is very, very informative. And started with, when you have fasting, the first thing is the visceral fat. Probably that is the reason when you fast, the blood sugar comes down. That's a wonderful message. And the 60% of the brain is the fat. So you know, brain is a fat, but the excess fat is dangerous. That's again insisted. And the ectopic factor more innervated by the sympathetic neurons. That's why it's metabolically active. And of course, there's a sir said that liver fat is pre-diabetic and pancreatic fat is over to diabetes. So wonderful information, madam. Thank you, sir, for your great presentation. Thank you both, sir.